Good morning, everybody. We'd like to get started. So we're still basking in the glow of the wonderful psychiatry residency match and psychology intern match. It's wonderful that we have such motivated, talented, and accomplished young people coming in to bring energy and enthusiasm and creativity to our department every year. We just wanted to remind people about a couple of things. One is that following Grand Rounds today in this room, we'll have the Chief Residence Diversity Town Hall. And the topic for the discussion today is the art in the department. And there's been a lot of hard work and thought and discussion related to that. And I look forward to continuing that after in the town hall meeting today. In terms of the upcoming Grand Rounds presentations, next week is Good Friday, so there's no Grand Rounds presentation. And then the following week is this very interesting Poynter Fellowship. Poynter Fellowships are Yale University-wide programs to bring people to the community. And we're having the author Leslie Jamison, who's going to be talking about the Recovering Intoxication and Its Aftermath, which is a remarkable book that has drawn a lot of attention. The following week, that's the 13th of April, Peter Ash will give the Yokelson lecture about adolescent culpability. The title is, But He Knew It Was Wrong, Delinquency and Adolescent Culpability, which is obviously a complicated but important question in forensic psychiatry. Just to let you know that on the 26th, I think it's the 27th of April, I'm going to give the State of the Department address. Usually I give that in June. I was going to give it on June 1. This year, but it turned out that that is the date of the celebration of 100 years of women at Yale, and I thought it would be bad form to give the department lecture on the same day. So, I'm going to be doing that on the 27th of April, so just keep that in mind. So I would like to, at this point, introduce Stephanie O'Malley, who's going to introduce our speaker today about very interesting work about the body and the brain and alcoholism.
Thank you, John. It's my pleasure today to introduce Dr. Marcia Bates. Dr. Bates is a distinguished research professor at Rutgers University in the Department of Kinesiology and Health, previously at the Center for Alcohol Studies. She completed her doctoral work in neuropsychology at Rutgers University prior to joining the faculty. And while at Rutgers, she's had many leadership roles, including the acting director of the Center for Alcohol Studies and president of the Division 50 of the American Psychological Association. She's also received many distinguished awards for service from the APA and other organizations. And importantly, she's really been recognized for her mentoring of faculty and fellows in team science and multidisciplinary research. Regarding her own research, she's made innumerable contributions to the alcohol field. These include, in her early work, the identification of risk factors for alcohol-related cognitive impairment, the influence of premorbid impairment on treatment outcome, and predictors of cognitive recovery following treatment. She's also identified and characterized a neurocardiac mechanism of behavior change through the study of heart rate variability and has now developed a new approach to improve patients' ability to withstand craving by regulating the bidirectional communication between the heart and the brain through a simple behavioral breathing technique. And we're going to hear some of that work today, which I think should be quite exciting, and I hope will get everyone thinking about other applications to research and practice. So her talk today is Recovery from Addiction, Harnessing the Body to Support the Brain. So please join me in welcoming her to the podium.
Hi. So I'd like to very much thank Stephanie O'Malley for inviting me here today and let you know how honored I am to be able to come and talk to you about the research that I'm doing. I want to start off by acknowledging National Institute of Health, American Psychological Association, State of New Jersey, the Christopher D. Smithers Foundation, the Alcoholic Beverage Medical Research Foundation, Stanley Foundation, and Rutgers, who have provided financial support for my research program, and I have no financial conflicts of interest to declare, unfortunately. So today's learning objectives have to do with thinking about or understanding what might be some of the practical outcomes or benefits from elaborating the neuroscience models of addiction that we have to include mechanisms that reside in the body and that relate what's happening in the body to the brain. And the particular mechanism we've been interested in is the baroreflex mechanism that ends up participating in our ability to think and respond emotionally and to engage in adaptive and flexible behavior. And also touching on new ways that technologies that are now available that might enable us to import interventions that we previously could only do within the laboratory or within the clinic out into the real world for people to use in their daily lives. So I'm going to touch on all those topics, but perhaps not in a really linear fashion, but that's okay because we're talking about dynamical systems. But I did want to provide you with a brief overview just to kind of structure my comments. So I'll first off present the problem of relapse prevention that's particularly important in the areas of addiction. Discuss the baroreflex loop, the neurocardiac processes that affect cognition and the control of behavior. Talk about heart rate variability as a really sensitive proxy of the baroreflex loop functioning and show you some data about its sensitivity to different kinds of loads and static and dynamic risk. Introduce behavioral modification of baroreflex sensitivity through resonance-paced breathing and show you some preliminary data that we've collected on changes in brain activity that occur during and following engaging in resonance breathing. And then finally describe a clinical trial we have of us using a smartphone technology to import the resonance breathing intervention into individuals' everyday lives, and finally end up with a computational modeling approach that we're trying to use in the spirit of precision medicine to be able to predict how the resonance breathing intervention is working and who it might be most valuable for so that we can match individuals to treatments. So all the research that I'll be presenting today is team science, and I'm really representing the work of many individuals. And I wanted to acknowledge in particular Evgeny and Branya Vistilo, who are the physiologists that I work with in the lab, as well as Jen Buckman, a neuroscientist. Our neuroimaging collaborator, Bharat Biswal from the New Jersey Institute of Technology, and our computational modeling collaborators, Igor Mezik and Maria Fonobarova from the University of California, Santa Barbara. So this is the essential problem. We have a number of interventions for alcohol and drug use disorders, CBT, motivational interviewing, psychopharmacological approaches, and they're all really effective initially in preventing substance use or in effectively treating substance use disorders. But when we look over time after individuals leave treatment, and this could be after 3 months or 6 months or a year, there are really precipitous drop-offs in the rates of abstinence that people are able to maintain out in the real world. And the outcomes for alcohol use disorders are not really that different than they are for other chronic relapsing mental and physical disorders. So as you can see here for drug addiction, diabetes, hypertension, asthma, large relapse rates, so to speak. And it really highlights the idea that we need to find new ways to extend the effectiveness of treatments over time and outside the context of treatment. So I heard a talk last week by Arthur Evans, who's the new CEO of the other APA, and he was talking about, the general conceptual model of addiction treatment. And basically that model is there's a person, they have an alcohol use disorder or some other disorder, they go into treatment, it's successful, and then they return to their beautiful life as normal. And, I spent a long time talking about, like, what's the matter with that model? And, there are many things the matter with the model. And first of all, it doesn't take into account the varying contexts and co-occurring additions, the things that the person brings with them and their specific problem that they're being treated for. Most people never even make it into treatment. Those that do are often receiving a kind of black box intervention to the extent that we don't really understand the active mechanisms that underlie their success. And then perhaps one of the biggest problems is the life that individuals go back to are often disorganized from their disorder. And even if they're not, and there's a lot of supports, they're going back to all the cues and the triggers and the things that were intimately tied up with their addictive behaviors to begin with. And that's a real problem. And so there's a critical need then, in our view, to develop relapse tools that can be deployed outside of treatment, after treatment, when people encounter or anticipate triggers that are going to initiate their substance use behaviors. And, we know from a lot of research that the initiation of action processes, behaviors that get people into trouble are often automatic. And so the tools that we use to counter these are often cognitively driven and require conscious attention, but they can be undermined in the moment immediately by automatic processes that occur via, priming by perceptual representations or cues in the environment, their salience, incentive, emotional quality, and other processes that generally operate largely outside of conscious awareness. So our real question is, let's think about the systems that support these automatic processes that can undermine executive control of behavior, because that's what's happening a lot of the time. And so one interesting possibility was suggested about 150 years ago, and this is Darwin commenting on the work of the French physiologist Claude Bernard, and said this deserves a special notice that when the heart is affected, it reacts on the brain, and the state of the brain, again, reacts through the pneumogastric nerve, which we now know called the vagus, on the heart. And so that under any excitement, there will be much mutual action and reaction between these two, the most important organs of the body. And so over the past 150 years, there's been an extensive amount of research that's been done that has very clearly articulated the system, the baroreflex system, which is this path of bidirectional communication between the brain and the body. And this is a picture of the central control portion of the baroreflex loop that is responsible for the efferent signaling from the brain to the body to control the autonomic nervous system, the parasympathetic and sympathetic nervous system. And there's also a bodily component to this loop, and that is primarily made up of the baroreceptors, which are mechanostretch receptors. They're located throughout the body, but the most important ones for the cardiovascular system are on the aortic arch and the carotid artery. And the firing of these baroreceptors is fed back to the brain from the heart. And there's two real points that I want to make about the baroreflex loop and the central autonomic control of autonomic function. And the first is that it's clear from the distributed structures or regions that are involved, including the medial prefrontal cortex, the anterior cingulate, insular, amygdala, through the periaqueductal gray, down to the brain stem, that the organization is bidirectional at all points through these levels, and that there's no real structures or regions in the brain that are dedicated independently to the control of autonomic function. Autonomic function, rather, is controlled or mediated by the brain through important neural centers that are integration and relay centers, so that the information about heart rate and blood pressure and its regulation is integrated with cognitive and emotional processes that occur throughout the levels of the brain. So this particular figure also shows a common misrepresentation of the baroreflex loop that one often finds, and that I don't know if you noticed that the arrow, all of a sudden, when it got to the heart, everything was going in one direction. And we love the brain, and this just carries over oftentimes, but actually there's about 5,000 studies that show that other arrow is there too. And so the information is going in both directions. And so from that point of view, if we think about the some current neuroscientific models of substance abuse, and the Kubin-Volkow three-stage model is a very popular one. Again, we're becoming very sophisticated in terms of understanding at multiple levels the relationships between brain regions that are involved in instigating and supporting addictive behaviors. But the model ends down here in the brainstem. Right? It's also involved, but that's it. And so our idea is, what if we can elaborate these models so that they don't stop at the brainstem, but rather continue on to the rest of the body? And what if we can include the cardiovascular system in our models of addiction? And what if, over and above that, we have behavioral methods where we can upregulate and improve the way in which the body is communicating with the brain? Would it be possible then to potentially affect some of these neural processes that are going on that support and maintain addiction? And I don't have the answer to that question, but I think it's a very interesting question. So it's clear that it's possible that the baroreflex loop does play an important role in drinking triggers. The autonomic nervous system components of the loop are involved or serve a preparatory function that often operates implicitly to guide behavior. And there's two main ways in which this often works. And one is through attention allocation strategies, and the other is through energy mobilization. And it's interesting because these components, these autonomic nervous system components, they're implicit, they're automatic, they don't make demands on cognitive and attentional resources in order to operate, but they do end up contributing to the direction in which those attentional resources are allocated to the environment. Similarly, with energy immobilization, the autonomic nervous system ends up participating in very specific changes in arousal that are needed by the organism to energize to do absolutely anything. And, fleeing from danger and approaching a drink are just two examples. Whoops. So we think that the baroreflex loop is especially attractive for relapse prevention because it automates automatically and implicitly. It's operating at the level at which cues and triggers in the environment are also operating. But it's unique in that the adaptive potential of the system can actually be modulated through behavioral techniques. And we're really, again, interested in whether we can use these behavioral methods to upregulate baroreflex sensitivity and whether that training can then cascade to neural and other systems. And the particular proxy measure of baroreflex sensitivity that we use and that is often used in the literature is heart rate variability. And so essentially, heart rate variability is a measure of the differences in time intervals between the R spikes of the ECG. And when I first heard of heart rate variability, I'd assumed that if it was very constant, that would be the most healthy thing possible. And the physiologist immediately told me, no, you would be dead. And so you must have this variability between the interbeat intervals of the heart. And what these really finely grained millisecond differences between the R spikes represent are these really exquisitely tuned timing and magnitude adjustments that are made between the relationship between heart rate and blood pressure. And it turns out that the more finely tuned your system is to adjust heart rate and blood pressure to the magnitude of the challenges and things that you encounter in your life, the healthier you are, both physically and mentally. And so various measures of heart rate variability really provide a nice window into this kind of brain cardiovascular modulation of reactivity to triggers. And there are large literature showing that HRV is really a robust biomarker of health. So lower levels of HRV, good predictors of all-cause mortality, poor physical health, poor immune responses, inability to respond to acute and chronic stress, depression, other psychopathology. It can prospectively predict social competency in childhood. And the flip side is true, so that the higher the rates of heart rate variability, the more healthy and the better the prediction is about outcomes. So originally, when I first started looking at heart rate variability in my lab about 10 years ago, it was as a biomarker. And when we started analyzing the results of our studies, what immediately became clear is that heart rate variability is much more than a biomarker. It's an ongoing process that's dynamic and it's unfolding in real time. And we started to look at the ways in which it could give us information as a process about people's reactions in real time to various loads. And so the next few slides, I just want to show you a couple of examples of its sensitivity to different kinds of pharmacological and emotional loads, how it's diminished by acute alcohol intoxication and also by chronic heavy drinking, and also how these responses all vary with risk status. So there have been review articles written about the effects of acute alcohol on heart rate variability, and basically the literature strongly suggests that it dampens strongly heart rate variability, and the review articles focus primarily on dampening of high-frequency heart rate variability, which is the parasympathetic or vagal component. But in fact, it dampens heart rate variability overall and many more components other than just the vagal one. So this is just an example of data from one participant. This is the RRI trace. B1 is 5 minutes before drinking. B2 is 20 minutes later. Person is at about a 0.06 or 60 milligrams per deciliter. And you can see a massive decrease in heart rate variability, both the power of the oscillations and also the mean level. This individual also showed what is often found as an increase in heart rate following intoxication, although there's a lot of individual variability in whether that's shown. So when we think about changes I'm not looking now at high frequency, but rather a 0.1 hertz index of heart rate variability, which is in the low frequency domain. I'm going to talk a little bit more about what that means later. But I just wanted to walk you through this particular slide. So this is in a group of participants who haven't drunk any beverage yet. They're just in a regular sober state. This is their baseline level, average baseline level of heart rate variability. And these three bars represent changes that occurred from baseline in response to tonic, negative, positive, and neutral environments that were created by showing blocks of valence picture cues from the International Affective Picture System. And so the first thing that you might notice is relative to baseline. As soon as individuals are put in a context with cognitive emotional valence, there's an increase in 0.1 hertz HRV. And if in addition the cognitive emotional valence is, in addition there's a strong emotional valence that is either negative or positive, that there's even a further increase in HRV. So it's very sensitively responding even to the rather passive presentation of a cognitive or emotional valence or context. And so it's highly reactive to cognitive load. Then if you drink alcohol, the entire system, as you might expect, becomes depressed. And even though the system is depressed, you still see that there is heightened reactivity to the emotionally valent stimuli relative to the more emotionally neutral ones. So there's preservation of the impact of emotional tone in the environment, even though the entire system is depressed. I think I'm just going to skip that. And this is going back again now to look at changes in high frequency or parasympathetic index of heart rate variability in after a controlled beverage, a placebo beverage, and an alcohol beverage. And I like this slide because we've found, and we've replicated this actually in hundreds of participants now, is that males are much more depressed in terms of their high frequency HRV following acute intoxication than women are. So I think that women maintain a little bit more of their adaptive potential following intoxication. We've actually looked at sex effects in many different ways and think that some of what we're observing may be related to cardiovascular mechanisms that are known to be protective in women in general. So this is just showing some examples of background characteristics that can affect individuals' responses. These are back at the 0.1 hertz HRV measure. We're looking at individuals who are family history negative for alcohol use disorders, those that have one first-degree relative, and those that have a first and second-degree relative. And you can see that the HRV reactivity from baseline to the negative, positive, and to some extent neutral emotional cues is not significantly different between the groups. However, when we look at responsivity to alcohol-related cues, you see that the family history group is much more reactive to the alcohol cues than the family history positive, more reactive than family history negative. This is another example where we were looking at young adults who are at high risk for developing alcohol use disorders versus those who are low-risk drinkers. And their reactivity to negative emotional cues was elevated, as well as to alcohol and drug cues, which I'm not showing here. So there's a sensitivity to the environment, to more stable risk factors that individuals have, and also to momentary loads, including alcohol. Now, in individuals who have alcohol use disorders, who are chronic heavy drinkers, the baroreflex loop is impaired in many different ways. And again, these literatures have been reviewed, focusing primarily on heart rate variability. But you can see from the list of impairments here that the baroreflex loop is being impacted in a chronic sense, both centrally and peripherally. So it's both increased sympathetic and decreased vagus or parasympathetic effects, negative vascular effects, and the like. And as a matter of fact, we've just finished a study where we found some vascular effects of chronic vascular effects of alcohol in young, healthy binge drinkers. They're very subtle, but it looks like it might be an initial sign of the well-known increased risk of cardiovascular disease that's present in samples with alcohol use disorders. And again, just an example of data from women entering treatment. Those who had drunk the most amount of alcohol in the preceding 30 days had the lowest level of baroreflex sensitivity coming into treatment. So the process is interesting, but the idea that it's a modifiable process is even more interesting. And there are actually any number of ways that one can intervene and modify heart rate variability, and it can be done through rhythmical muscle tension. It can be done through paced sighing. We can do it a little bit by presenting salient cues. But one of the strongest and most immediate and well-validated ways in which to increase heart rate variability and baroreflex sensitivity is through resonance-paced breathing. And basically, resonance-paced breathing is 6 breaths per minute. So it's slow. It's about a third to a half of the normal breathing rate. It normalizes breath into a rhythmic pattern. We often teach individuals to inhale slowly for about 4 seconds, slowly but not too deeply, and then exhale for about 6 seconds. It takes some practice to be able to do it comfortably. Some individuals are much easier to train to breathe in that way. The only real thing that you want to be careful about is not breathing too deeply, because then you'll hyperventilate and you'll actually initiate all the opposite effects of what you're trying to accomplish. So these are data, again, from our lab, just showing an example from one subject that's highly representative. So as soon as you start breathing at this rate, you get immediate cardiovascular changes in the instant. And you can see that the oscillations in heart rate increase dramatically, and that's associated with health. However, there's no real change, or there's often not a change in average heart rate. So you can see that heart rate and heart rate variability are two very different processes. There's large oscillations that are also found in systolic blood pressure that happen immediately, but unlike heart rate, systolic blood pressure goes down. And actually, heart rate variability biofeedback is an empirically supported treatment for high blood pressure, but most people have never heard of it. Most doctors don't recommend it. And then finally, the example with baroreflex sensitivity, you get massively increased sensitivity of the system, and which means that your system is becoming more finely tuned to adjust blood pressure in relation to changes in heart rate. So there are probably, at least 2 underlying mechanisms that make breathing at 0.1 hertz induce these large oscillations that are so healthful. And one mechanism is simply respiratory sinus arrhythmia. It's the increase in heart rate that always occurs when we inhale, and the decrease in heart rate that occurs when we exhale. But the effects of respiratory sinus arrhythmia are kind of geometrically increased by stimulating the baroreceptors at this rate of 0.1 hertz, because it's a resonance frequency of the cardiac system. And so we have both the respiratory sinus arrhythmia effects and the resonance stimulation of the baroreceptors, and together these two things synchronize respiration and heart rate, which under normal breathing conditions show no relationship, no clear relationship to each other. And during the course of resonance breathing, you see that they are perfectly superimposed, creating these large oscillations in the system. And this is just looking, again, in another way at the effects of resonance breathing, where we have the spectral density function of the RRI. And you can see there's a massive increase in power, but it's all piled up here at 0.1 hertz, which is the rate at which you're breathing. And then you have some harmonics at 0.2 and 0.3. So there is, pockets of empirical support for heart rate variability biofeedback, which resonance breathing is the essential mechanism of, in accomplishing good clinical symptom remission or decreases across many populations. One of the issues, though, with respect to substance abuse populations is this intervention, a standard form of it goes for 10 weeks. It requires an hour session in lab or in clinic, plus 2 20-minute sessions practiced at home every day. And so when we've tried to look at that, we've gotten, as you might imagine, really minimal compliance, especially with the home practice part of it. However, in other disorders where there's more intrinsic motivation to feel better and you feel the immediate effects of the resonance breathing on symptom remission, you're more likely to have people comply. So we thought a lot about, what are other ways in which we might use this without using these long-term in-laboratory training sessions. And in looking through the literature, we started to notice that 0.1 hertz resonance breathing may in fact be a common mechanism going across a number of other interventions that are known to improve health. And so we've looked at heart rate variability biofeedback. These other areas, there's no training to breathe at 0.1 hertz. There may be training to slow your breathing, but what has appeared is that individuals that are appropriately doing these interventions spontaneously start breathing at 0.1 hertz. And the article I liked the best was the one about the rosary. I think it was a British Journal of Medicine from 20 years ago. But saying the rosary will actually can induce 0.1 hertz breathing, but only if you do it in Latin. So Hail Marys didn't work, Ave Maria, that's where you go. In any event, not the full mechanism, but we start thinking that this may in fact be one mechanism that underlies some of the positive benefits across these different interventions. So I'd like to switch gears quickly and just talk to you about a couple laboratory studies that we're doing right now to try to understand what's happening in the brain when people are doing resonance breathing, and also if you engage in resonance breathing, could we have a short-term impact on the way individuals relate to appetitive cues? And then end up with a computational modeling to try to get that how and for whom question. So again, the next several slides I'm going to show you, the studies are in process. The results aren't final. We don't have a lot of power at this point, but I just wanted to give you some idea of our preliminary results. So when we image individuals, we always simultaneously assess ECG and other physiological signals, and regardless of what BioPAC and the manufacturers tell you, it's really hard to get a clean signal in the magnet. So the work is kind of difficult, and you lose individuals to movement artifacts, especially when they're doing resonance breathing, which tends to make people move their head a little bit. But in any case, looking at some clean data with clean signals, We validated, in fact, that the individuals were breathing at 0.1 hertz, where we got this big pile up in power here. And we found that during the actual course of breathing, that there was significantly increased activation in the brainstem and the cerebellum, and that there was decreased activation in the medial prefrontal cortex. So the brainstem obviously is the first integration point of the central autonomic network that I talked to you about, and is the first point where the information from the heart is relayed upwards to the brain. That makes sense. We always get cerebellar activation when you have individuals do paced breathing because it's conscious muscular control. And then, you know, we found the decrease in prefrontal cortex. And I guess I didn't mention before that individuals often report during the course of resonance breathing and shortly afterwards that it's very restful and, you know, positive feeling in terms of dampening any kind of sympathetic arousal that might be going on or anxiety. So not 100%, but oftentimes you get these subjective reports about the really pleasant feelings of engaging in resonance breathing. And we thought that potentially that this decrease in, you know, cortical activation, as long as we didn't have limbic or other systems that were activating to complicate the picture, may have something to do with reports of relaxation and stress reduction. It's obviously can be tested. Oh, okay. And then the next study I just basically wanted to mention was where we had individuals who either were non-treatment seeking individuals with alcohol use disorders or very low-risk drinkers. And we brought them into the laboratory. I think I can switch to this. And our basic paradigm was that everybody initially saw neutral cues, and then we used a visual analog scale for them to rate their craving for alcohol, 0 to 1. Then they saw a set of alcohol cues, which were personalized to their preferred beverages. We did the craving again. Then they were either randomly assigned to breathing at 6 breaths per minute or a vanilla control task where they just watched the LCD screen change colors and counted the number of blue squares. And following the intervention, then we had a second unique set of alcohol cues and had them do the VAS cue rating. Oh, that's just the, okay. So in what we found essentially that was in the group that was breathing at 6 breaths per minute, we found heightened activation during, in the second exposure to alcohol cues compared to the first. In the left posterior cingulate cortex, precuneus, frontal medial, subcallosal, brainstem, and paracingulate. And then we also saw less activation or greater activation during the first time they saw the alcohol cues in the in visual centers, the left inferior temporal gyrus, the left fusiform gyrus, lateral occipital cortex. We also looked at changes in craving, and so far what we found is that the group that was engaged in the resonance breathing, rather as a whole, rather than experiencing a decrease in craving, did not show the normative increase in craving that the group that didn't receive the breathing showed when they saw the alcohol cues. So reactivity of the alcohol cues tended to increase over time throughout the first cue exposure and the second cue exposure, and that appears to be, it was interrupted in the group that had done resonance breathing. So to summarize there, so the prefrontal deactivation that we observed during resonance breathing was then followed by a rebound in prefrontal activation in response to the alcohol cues. And that was accompanied by reduced visual processing of the cues, which would be consistent with the idea of less attention capture by the visual cues following the 6 breaths per minute. We definitely need more power. We haven't been able to look at the interactions yet and understand how the persons with use disorders are different from the low-risk individuals. And then we also have the bane of random assignment in small studies where the group with alcohol use disorder that was assigned to the breathing intervention had, for whatever reason, much lower levels of craving when they came into the study than the others. So we basically have to increase our N before we can look at the more complicated interactions between the use characteristics of the individual and how the interventions were working. But we do think, that there's really, not just our lab, but other labs are really starting to provide evidence that it will be useful to think about respiration and cardiovascular processes in a more sophisticated way than just artifacts to be eliminated from fMRI activity studies, which for the most part is how cardiovascular and respiratory effects are treated. These are actually integrated systems, and we don't want to interpret mechanical effects as neural effects, but there's obviously a need to separate those two aspects of cardiorespiratory effects so that we can understand real effects on neural processes versus mechanical effects of blood flow changes. So then the last study that we're going to talk about now is that an in vivo study of the potential in-the-moment benefits of resonance breathing. And so in this study, we wanted to evaluate the short-term momentary effects of resonance breathing because they seem to be incredibly strong. And actually, the mechanism through which even full courses of heart rate variability biofeedback works is not entirely understood at this point. So in normal populations, a course of HRV biofeedback treatment after 10 weeks, you'll have a chronic increase in baroreflex sensitivity. In clinical populations, that isn't seen. However, you do see improvement in clinical symptoms. And so an interesting hypothesis is that it may not be that the intervention causes these long-term chronic effects that sustain, but rather that it's the masked, immediate, and shortly thereafter effects of the intervention that are the most important. And ideally, what I think would be the best outcome is if one could train individuals to engage in resonance breathing in the moment when they anticipate or experience a stressor, that over time with consistent mapping of the breathing and the stressor, that you may develop an alternative automatic process that would actually compete with the emotional valence of the cue. So this is our project impact, in-the-moment protection against capture by triggers. I'm not very good at acronyms usually. We worked on that a lot. But it's a very interesting sample. We're doing the study in a community treatment center that serves parenting women who have alcohol and other substance use disorders, so alcohol and opiates. Actually, opiates now are the most prevalent disorder. The community treatment center is trauma-informed. It's a very trauma-heavy sample. They use elements of cognitive behavioral and motivational interviewing, and it's an eclectic but reasonable and strong treatment approach. And what we're doing is just doing an add-on to the treatment approach and randomizing women who come in who are interested in participating to either learn how to do the resonance breathing, or we randomize them to a group where they do a sham breathing. But I'll talk about that in a moment. So there's a lot of recent buzz about the use of digital health technology improve health in a lot of contexts, but for the most part, the field has focused on passive assessment of signals, which are then relayed through pipelines to your doctor's office or your clinician or whatever, who can evaluate that. But our need was different. We needed something that just didn't collect data from the participant, but actually that they could use to deliver the intervention to themselves. So our goal was to get the intervention out of the laboratory that required all that kind of stuff and go out into the real world with iPhones or smartphones. And in that way, individuals would be able to self-medicate whenever they felt the need. And the reason that this is possible is because of PPG. So smartphones have a camera and a light-emitting diode, and that diode can be used to reflect changes in blood volume that occur during the cardiac cycle by eliminating skin and measuring changes in light absorption. So essentially, you're holding the iPhone in your hand and just putting your finger over the camera. And then there's a lot of work that gets done on the PPG signal before it is interpretable. And so basically, we looked for iPhone apps to teach participants to change their respiration-heart rate relationship from this to this. And there are many different apps on the market. HRV for training is one of them. Basically, the camera's on the other side. It'll give you your PPG trace. It may tell you your heart rate in the moment. This one has a timer in it. Most importantly for us is this breathing pacer. And so there's two ways in which one could go about having individuals breathe at resonance frequency. And one is through actual biofeedback, where you adjust your breathing rate to maximize the oscillations. And in the laboratory, that's easy because you're able to measure and display respiration as well as the RRI, and individuals can find ways to breathe that match them up. On the phone, you only have this trace, and so there's no real ground truth about what's a maximum oscillation. But a really useful alternative is just to use the breathing pacer, and it can be set for for many different frequencies, and we set it at 0.1 hertz, and we just train the women to inhale as the pacer goes up and exhale as it goes down. And we also ask them when they are using the app to tag it. You know, we didn't want to make a lot of demands, but we want to know the situations in which they're using it. And the only real substantive or clinical add-on that we do to the treatment that they're receiving is we work with them a little bit more in terms of identifying triggers for use. And based on past research, going through negative situations, positive temptation situations. Because what we're asking them to do is to pull out the phone and use the app just for 5 minutes at any time they get upset or think that they anticipate that they're going into a situation that's going to be challenging for them. So we do pay a little more attention to that. So I don't have any data to show you. We're like right in the middle of the clinical trial. We're looking, of course, at feasibility. We've adjusted our incentive structure a couple different times. Women with small children have small children that take their phone. So they're supposed to bring the phone in each week to their treatment center so that we can dump the HRV data off it and get information about usage. And oftentimes women forget to bring it in or whatever. So it has been a little bit challenging, but we are collecting data, and so we shall see. We're of course going to look at alcohol and drug use outcomes, but we're also very interested in both acute and chronic changes in cardiac physiology. We image the women pre and post treatment, so we can look at neural networks, and we're also assessing attention, cognitive functioning, and those sorts of things. And then The last thing I want to move to then is prognostic models, you know, finding out who's most likely to use it, but also, as important, finding out who's mostly going to benefit from it. So we all know that there's substantial differences between individuals in how they react to things in the environment. And there's also substantial differences between individuals in, even if they become really upset, how long it takes them to regain themselves and to calm back down. So there are all sorts of individual variabilities there that would seem to be quite relevant to whether a person would benefit from resonance breathing or these interventions that affect the baroreflex loop or not. And so, just to be really complicated, we decided in collaboration with our computational modeling team that if we could computationally model the baroreflex and observe and have information about a lot of the processes within the body that are changing, that aren't really observable without invasive means if you weren't using computational modeling, that it might provide us some information about who was experiencing benefits from the intervention, how things were changing internally, and that maybe we could use that information to then predict, after taking a 5-minute sample of data, who might be most likely to benefit. So we started out with a really well-validated model by Ursino and Magosa. It was a canine hemorrhage model. We adapted it to the human condition. And actually, we were able to validate the model, and using respiration as an input, we were able to very nicely reproduce the RRI spectrum and the blood pressure response of participants. And so there are about, 90 parameters in this model. And what we found was that only about 7 of them were really important in terms of changes between normative breathing and resonance breathing. And I want to give you an example of just one of them, which was this measure of improved blood flow to internal organs that occurred during resonance breathing. And so you can see that during 2 different baseline conditions that we had, there's the distribution of this CSP variable. And then when individuals breathe 6 times per minute, you see on average there's a very nice increase in blood flow. But you'll also notice that there's a fair amount of variability in that increase in blood flow. And so when we mapped the responses of individual participants, what we saw is that most individuals did show the average response. So these were during the 2 baselines, and then there was this large increase during resonance breathing. But we also found about 1/3 of the sample that didn't look at all like that, and either showed no change or showed the opposite change that one would expect, or some other irregular pattern. And so the idea is that we want to look at this as well as other variables where we found the same sorts of typical and atypical relationships to see if we can predict those individuals who will or will not most likely benefit from resonance breathing. So I'm not sure when I'm supposed to end up. Got a couple minutes? Yeah. Okay. So the last point that I really wanted to make is that it's been very useful looking at the baroreflex loop and thinking about another system as well as neural systems that end up driving behavior and starting to look at how those 2 systems relate. So We also had the idea that, like, let's start looking across a lot of different systems that we're measuring responses from. And let's see how integrated these responses are within the individual across systems. And so what this is a heat map. Each row is a different participant in the heat map. And this represents individuals' level of self-reported arousal to negative emotional cues. This is a measure of high frequency or vagal, HRV. And this is a measure of heart rate reactivity at the 0.1 hertz band. And so, and they're arranged in order of intensity of self-report. And so what was really surprising to us is that there are certainly some individuals who tend to be congruent in their self-response and their different response of different components of their heart rate variability. However, there are also individuals who are totally incongruent across these systems, about as mismatched as possible. And then the rest of us, I guess, fall somewhere in the middle. And so I think one thing that really hasn't been addressed much to any extent is thinking about whether this might be another source of individuals, about another source of information about individuals that could be clinically useful. That is, how internally integrated response systems are within the individual. It also kind of shows the folly of, I know in psychophysiology experiments, we're often asked, like, did self-report correspond to your measure of arousal? And so you do a correlation, and you're like, no, or yes, but just barely. And it's not a linear problem. It's a problem that obviously varies by individuals. And so if you throw everybody together, you're really not going to find anything, but it may be useful. And then similarly, we looked at, again, heat maps arranged in order of intensity, this time based on expressive facial reaction to the cues, and a parameter of vagal nerve firing from the computational model. And again, we find individuals whose expressive facial reaction is very consistent with our estimate of vagal nerve firing. But there are a lot of individuals who aren't. And when we were looking at these data in lab meeting, a couple of the RAs said, oh, we could have told you that, because when participants are looking at the cues, sometimes we notice that their physiology is just flat, but they're making expressions and acting as if the cues are really affecting them positively or negatively, but there's not really much happening with physiology. And so during the assessment occasion, the individuals who were collecting the data were kind of noticing different types of people, like highly outwardly reactive, very low physiological responders, individuals whose physiology was going off the roof, but they had very stoic faces. And so, again, there are individuals where these systems are integrated, others where they're very mismatched, a lot of people in between. And I guess I just want to leave you with a question about what all that means. But I have a suspicion that integration within the individual across systems is probably a really important source of information that we should be looking at. And so thank you, and I'll leave you with this nice quote from Carlos Santana.